Okay, let's talk about cervical cerclage. It's one of the most important tools we have for preventing preterm birth. But here's the thing, knowing when to place that stitch, and just as importantly, why, well, that's the key. In this explainer, we're going to break down the latest evidence-based guidelines from the RCOG so you can walk away knowing the precise indications for this procedure.
So, what is a cerclage, really? In the simplest terms, it's a stitch that helps reinforce the cervix during pregnancy. Now, the original thinking was all about cervical insufficiency, this idea of a weak cervix. But we now know it's a bit more sophisticated than that. Yes, the stitch gives mechanical support, but it also does something else that's absolutely crucial. It helps preserve the mucus plug. Think of that plug as a barrier, protecting against ascending infection, which we know is a huge driver of preterm birth.
And just so you know where all this info is coming from, we're not just making this up. We are pulling directly from the RCOG's Green Top Guideline, number 75, which came out in 2022. So everything you're about to hear is current, clinically robust, and exactly what you need to know for your practice.
All right, here's our roadmap. First, we'll cover the fundamentals, the different types of cerclage. Then we'll get into the real nitty-gritty, the specific evidence for when to place a stitch. After that, we'll look at the high-stakes world of the emergency cerclage, touch on some advanced techniques, and then wrap it all up with management, removal, and the key takeaways. So, Section 1, the fundamentals. Honestly, the most important change in this RCOG guideline is all about terminology. It's a big push away from vague terms like prophylactic or rescue. Instead, we now have a really clear system that's based on the actual clinical reason, the indication for the stitch. First up is the history-indicated cerclage. The name really gives it away, right? This is a purely preventative measure. It's something we offer to women who are completely asymptomatic, usually between 11 and 14 weeks, and it's based entirely on their past pregnancy history. No scans, no exams needed. The history is the trigger.
Next, we have the ultrasound-indicated cerclage. Now, this is a therapeutic stitch. It's placed later, between 14 and 24 weeks, but only after a transvaginal ultrasound shows us that the cervix is actually shortening in real time. So again, the woman has no symptoms, but the scan has flagged a problem that's developing right now. And finally, the emergency cerclage. This is a whole different ballgame. You can think of this as a salvage or rescue procedure. This is for when a physical exam reveals the cervix is already dilating and, crucially, the fetal membranes are exposed. It is a very different, very high-stakes situation where we are literally trying to salvage the pregnancy. This table is a great summary of those key differences. For a history-indicated stitch, the trigger is the past. For ultrasound-indicated, it's a short cervix on a scan now. And for an emergency cerclage, it's what you find on a physical exam. The basis, the timing, the clinical status, they are all distinct. Getting this clear in your head is absolutely fundamental to using cerclage correctly. Let's move on to Section 2 and see how this all works in practice. We're going to get really specific now and look at the evidence-based criteria for offering the two planned types of cerclage. This is where the guideline really tells you what to do. When we're thinking about a history-indicated cerclage, there is one number that is the absolute key to the RCOG recommendation, and that number is 3. And here it is, straight from the guideline. This is a grade B recommendation. A history-indicated cerclage should be offered to women with 3 or more previous preterm births. Now, why 3? Well, it's based on analysis from a major trial, which found this was the group that got a clear benefit. For women with just 1 or 2 previous preterm births, it's not routinely offered. So the obvious next question is, what do we do for those women with 1 or 2 previous preterm births? The guideline recommends serial ultrasound surveillance of their cervical length. This strategy is smart. It helps us pick out the women who will actually benefit from a stitch while avoiding an unnecessary procedure in those who won't. Which brings us to our next key number. During that ultrasound surveillance, this is the measurement that is your trigger for action, a cervical length of 25 millimeters or less. And this is a grade A recommendation, which is as strong as it gets. For women with that history of preterm birth who you are monitoring, if their cervix shortens down to 25 millimeters or less before 24 weeks, they should be offered an ultrasound-indicated cerclage. It's a really clear and powerful piece of guidance. All right, Section 3, the emergency cerclage. We're definitely shifting gears here. This is the most acute scenario, where the cervix is already open. Making the call here involves a really careful conversation with the parents, balancing the risks and the potential benefits.
So what is the potential benefit? What are we trying to achieve with this rescue procedure? Well, a systematic review found that compared to just watchful waiting, an emergency cerclage might prolong the pregnancy by an average of 34 days. That's over a month of precious time.
But we have to look at the whole picture. So, on the plus side, yes, it can delay birth and cut the chance of delivery before 34 weeks in half. That's big. However, and this is important, the data showing it actually improves the baby's long-term health is pretty limited. And on the flip side, the procedure is very likely to fail if the cervix is already dilated more than 4 centimeters or if the membranes are bulging out.
Knowing the contraindications is absolutely critical to avoid doing harm. A rescue cerclage should never be performed if there's active preterm labor, if you see any signs of infection like chorioamnionitis, because the stitch could just trap the infection inside, or if there's ongoing bleeding or ruptured membranes. These are absolute no-goes. Okay, let's move into Section 4 and look at some of the more advanced topics. We'll cover different surgical approaches and talk about some special patient groups where the evidence gets a little bit murky. So the standard approach is the transvaginal cerclage, the TVC. But what happens if that has failed in a previous pregnancy? Well, that is the main reason to consider a transabdominal cerclage, or TAC. This is a much more invasive procedure. The stitch is placed way higher up through the abdomen, and a huge difference is that a TAC means delivery must be by cesarean section, and you can even place it before someone gets pregnant. It is so important to know when cerclage is not advised. For multiple pregnancies, like twins, the guideline is clear. It is not recommended. In fact, meta-analysis show it doesn't help and might even cause harm. For other groups like women who've had cervical surgery before, like a Let's procedure or a cone biopsy, the role of cerclage is just uncertain. We don't have enough good data. The same goes for women with uterine anomalies. And on to our final section, management, removal, and the big takeaways. The procedure's done, the stitch is in, so what happens next? And what's the plan for getting it out? The removal plan really depends on the situation. Electively, it's a simple procedure done in clinic around 36 to 37 weeks. If labor starts early, that stitch has to come out immediately to prevent the cervix from tearing. If the waters break preterm, what we call PPROM, we usually recommend removal because of infection risk, though a short delay for steroids might be okay. And finally, that transabdominal stitch, it stays put. Delivery will be by C-section. So, where do we go from here? Well, the guideline itself points out the big unanswered questions. Can we improve outcomes by combining cerclage with other therapies, like progesterone? How can we get better at figuring out exactly which patients will benefit, especially after they've had surgery on their cervix? These are the questions driving the research right now, and the answers are going to shape the future of how we prevent preterm birth.